8,000 cases with 23,000 deaths. In Canada, we're up to about 25,000 cases, 650 deaths. About half of the cases are in Quebec, and about 360 deaths are in Quebec as well. In Ontario, we are at 7,400 or so cases, which represents 400 from the previous day, which is about, I would say, about a 6 to 7% increase. And I'll talk a bit about that later, why that's significant. In terms of locally, at our health unit, I'll just go over some of the numbers, and I'm actually going to try to share the screen with you. Share, and let me see if I can go local. There we go. I think you can see my screen. And so just to give you an update, as of yesterday, we had 60 cases. There's sometimes a discrepancy between ours and the ministry. It has to do with how quickly they get the results versus us, because they're two different sources that have to merge. But we're up to 61 cases, I can tell. And just to sort of show you again, these are date of onset of symptoms. And so you can see we had a bit of a peak here where we had, cluster of cases here around the middle to the end of March. And then we've had trickling of cases coming this way. Our total amount is, like I said, will be corrected to 61. But what I wanted to share with you as well, and actually just you'll know as of tomorrow, we're actually going to be putting in a number of cases in Cornwall, number of cases in SDNG, number of cases in Prescott Russell. We're going to put those in tomorrow, and there'll be a little map moving forward. But I just wanted to give you a bit of a sort of a bird's eye view of what's going on provincially, and sort of compare us to others. I want to compare to others because I want to explain sort of what's going on and what we're seeing provincially, so people can understand better. If you look at the number of cases in Ontario, and if you look at the way they're distributed, this graphic here shows confirmed cases, and this graphic here shows symptom onset. It's kind of the same thing, but you can kind of see that you have clusters. The darker the blue, the higher the number of cases. And this is cases per, total cases that we see. And so if you look at sort of the area of Toronto, the cases started here, and then you can see slowly those areas there. So it's not surprising that the majority of cases are in Toronto, Peel, and then Peel, York, those areas, the GTA area, because the first cases started there. So you're kind of seeing kind of how it goes, it spreads outwards, and then you can actually then go see a bit more. This why you got to focus here, which is Ottawa, which has sort of an increased number of cases in terms of they're up to about 1,000 cases or so, close to that. And then you can see Leeds Grenville, which has a lot of cases as well, and that's attributed to some of their deaths that they had in the long-term care facilities. And we're kind of over here. And the other number I just wanted to sort of show you was in terms of overall. This is on the Ontario.ca coronavirus website. This is done by Public Health Ontario, and it compiles all of the data. And so I just put that there as a comparator, but also I want to put a bit of a spin on it. So because of the fact that you can see, so Ottawa, what they do is they break it down. They've had 500 and almost 600 cases here. So they're breaking it down to per 100,000 population, let's say. So Ottawa is 56. So this is our eastern area here, and you can see we're at about 29 per 100,000 population. Whereas if you look at Leeds, for example, they're 119 per 100,000. Again, it's because they have a lot of cases, and there are all of these clusters in long-term care facilities. Our total sort of average is 49.5 in our area, which is brought up by Leeds Grenville. But again, if you go back to these maps here, which show you the cluster of where the darker, the higher number of cases, you can actually see that, and you'll see that in Prescott Russell, that's where we started getting the cases initially, and then they spread to the rest of the area. And so it's not surprising that we started getting cases around here. A lot of people that live sort of in this tip of Prescott Russell around here work in Ottawa, for example. They commute to Ottawa a lot. So it's not surprising that we started getting cases here, and then it spread all over. So I just wanted people to contextualize that. And like I said, I'm actually at this point, and again, at this point, in terms of our statistics, we have 3 individuals in the ICU. Out of our 61, let's say, because we've added that today, we've had 29 that are resolved. And fortunately, we've had no deaths in our area, which is, I think, very good news. And I just want to keep it that way. So all this to say that although our numbers, and you could see sort of the way we've kind of peaking here, our graph isn't steep. It's not, we're not growing cases like this, we're growing this way. So it's small number, but I take a bit of comfort in looking at these. But then again, I also want to tell people that it's a result, because we're farther from the core, the nexus that I talked about here. Like we're here, rather, we're sort of, this area here is farther than this area here, and you can see that it's gonna, it's starting to spread. So what I'm trying to say is that although our numbers per capita are less than Ottawa or less than Toronto, we still have cases. We have 3 in the ICU in our area. So I think we need to continue. So it's a testament to 2 things. Number one, and this is reflected, our hospitals are not overwhelmed. Our hospitals still have capacity, all 4 of our hospitals, but it's reflective of that. But it's also reflective of the fact that I think, our distancing is working, but we need to continue. So I just want people to understand that our context is different than others, but like I said, it can switch very quickly. And one person infects 10, 12 people, then they can infect another 12, 20 people as well. So that's why it's important for us to be able to continue with the measures that we're doing. It's not, and people might say, well, you're not doing too bad, your curve is kind of flattening. The provincial curve, by the way, is maybe showing signs of flattening. Like I said before, kind of, if you look at kind of the way is going like this, you can kind of see that it's turning here a bit. There's some peaks here, but if you kind of follow it and goes this way, hopefully it's going to go that way as well. But it's not the time for us to let go and say, okay, now we're going to open schools, or we're going to go back to normal. And so I just wanted to show you the visual of this as we move forward. So I'm trying to now go back to my Zoom, and I'll hold on. Where am I? Pause share. There we are. So where do I see people? There we are. Okay, so okay, where am I? There we go. So the other thing that I wanted to sort of share with you is, again, in terms of some of the work that we're doing with basically our partners, our assessment centers. We're up to, just in our area, again, we're not including hospital visits or anything like that. We're just including our own assessment centers. Since we started the 5 of them, we've tested about 700 people. And so we got results from a lot of them, but we still have a couple of hundred pending. We should be getting those results as well.
I'm sorry to interrupt, Dr. Paul. We are still seeing your shared screen. I'm not sure if this is what you intend us to see.
No, I want to, hold on. Where am I? Where am I now? Hold on. Stop share. There we go. Sorry, I thought I stopped the share. Anyway, so yeah, thank you for that, Jenna. I had a lot of windows open, so I didn't know which one I was clicking on. What was I saying? Yes. So we've done about 700 tests so far in our assessment centers, and they're going very well. They're continuing. We've actually had some changes in regards to how we test and who we test, and that's been drawn out by some of the tragic things that have been occurring in long-term care facilities. As you know, half the deaths in Canada and in Ontario as well are due to residents that have died who have been infected in long-term care facilities, and that's kind of raised an alarm for a lot of us. It's not unexpected. It's a tragedy, and this morning I spent some time trying to explain it. It's essentially, what's happening is, we know that this virus will attack vulnerable individuals. It'll attack the elderly, and it'll disproportionately affect those with chronic underlying medical conditions. And so it's not surprising to us. And unlike with the flu, so I'll give you an example. With the flu, every year we have outbreaks and deaths, unfortunately, in long-term care facilities, but not to the degree that we're seeing with COVID. And I can explain to you. Number one, COVID now presents with symptoms that are a bit atypical. Now we've learned. So we used to think it's a fever, cold-like symptoms, and a cough, shortness of breath. But now we have some, especially in the elderly, you get, for example, just very non-specific symptoms. For example, headache, sometimes loss of memory, fatigue, very non-specific symptoms. So now moving forward, we're going to be testing those individuals. But notwithstanding that, when we have an influenza outbreak in these homes, what we have a protocol. Most of these individuals were vaccinated, albeit that the vaccine doesn't work effectively in the elderly, but we still vaccinate them. But as soon as there's an outbreak in a long-term care facility, we have tools to be able to reduce the spread of the virus or reduce the severity of infection in others in the home by giving them Tamiflu, a medication. It's an antiviral medication. We do not have that capacity with COVID. And so when an individual LTC, long-term care facility or retirement home, gets an infection in one or two and it spreads just by virtue of the way that they're set up, we don't have the tools, we don't have the necessary medications to prevent it. So that's why we're seeing these tragedies. So what we need to be doing is we need to be really focusing on the needs of these individuals, looking at their staffing, looking at PPE. So there has a whole slew of new recommendations that have come out in terms of everybody has to wear masks that works there, limiting the amount of people that go from one home to another, no visitors, testing individuals as soon as they're symptomatic, testing individuals when they enter. So we're working with Ontario Health Partners, with our long-term care facilities, with our retirement homes, and our group homes as well, and our lodging homes, because I think they're all at risk, to be able to ensure what they need. So the ministry has asked us to do a survey of all our long-term care facilities, all of our retirement homes in our area, to kind of see, okay, are you missing resources? Are you missing personnel? Are you missing personal protective equipment? Do you need testing support? Do you need infection control support? And we're collating that, and we're working with the ministry centrally in the Ontario Health East to be able to prioritize personal protective equipment, prioritize swabbing, prioritize infection control support, and prioritize even float staff that could come in and give a hand. So we're taking that very seriously. Like I said, in our area so far, we have not had any outbreaks in any of our long-term facilities, nor our retirement homes. But certainly we have to be very diligent because we know that they are a vulnerable population. So that is really sort of where we are with our updates. Moving forward, one of the things that I've been doing provincially is I sit on the provincial public health measures table, which we're looking at, okay, what sign do we look at, as an exit strategy moving forward? As you know, the emergency declaration has been extended to the middle of May. And so we have the next month now to kind of see where we're going. There's also increased emphasis on testing. There will be new, what's called point of care testing, an instant test that we will be apparently getting in rural areas first. The provincial government has bought 1 million kits, and these kits can test a swab on the spot where it's done and give you the results within half an hour or so. So these kits will obviously help facilitate us diagnosing and being able to diagnose people earlier, isolate them earlier, for example, particularly in the high-risk individuals, healthcare workers, frontline workers, residents of long-term care facilities, retirement homes, hospitals, and so on. So I think that will help us a lot. And also the availability of the testing will help us as we move forward to gauge what percentage of people are positive. I can tell you provincially, initially 1% of the people that were tested were positive. Right now, about 13% it peaked. Now it's around 10% provincially in terms of those who test positive. So the positivity, the rate of admissions, the rate of numbers, the rate of increase, the flattening of the curve will all be factors that we're going to be looking at provincial level to decide how quickly and when and what precaution is going to be sort of pulled back in terms of moving forward. However, for now, what we're trying to do is we're going to be moving forward with increasing enforcement and making sure that people don't congregate, don't go out, travel unnecessarily. There'll be some other measures put in terms of more enforcement of some of these measures, which I think need to be tightened in terms of ensuring that we continue to do this. But as we look forward, and I say that because there is a bit of a light in the tunnel. It's far away, but there's a bit of light there that we see. But like I'm saying, I don't want to raise people's hopes. I want to be cautiously optimistic. We talked about this morning with the Chief Medical Officer of Health during the daily call that we do. The numbers are showing some encouraging signs, but it's not a sign for us to let go and to say, okay, now we have to pull back. When I'm talking about pulling back, I'm talking about over the next couple of weeks, we'll decide if and when and to what degree we're going to pull back. So to me, that's quite an important point. But at least we're sort of thinking about that, because again, realizing there's a big impact socially, economically, schools out, all these things. Life is not normal. We know that. So I've got some calls here, some questions here. Have the criteria for getting the test been loosened? They've been loosened to include many other symptoms. They have, in terms of travel and so on, we're particularly aggressive with frontline workers, with people, residents in long-term care facilities, with police, with fire, first responders. At any sign, we will test those individuals. There's going to be an increased emphasis on those things. The other thing too is, or symptoms alone enough to trigger a test? It depends on the context, and it depends on how many, what the demand is and when it is. It may be in the future that we would be testing individuals with symptoms. At this point, we're focusing on certain groups, focusing, like I said, on the high-risk groups and persons that travel or have had contact with as well. The other one that I had here, some standard freeholder, what would you tell business owners who continue to not follow safety measures, plexiglass, and so on? First of all, we're working with them. We recognize that one size doesn't fit all. Our order my order was a full length, sort of a spectrum order that we expect them to follow. We are working with the smaller ones, recognizing that it may be more difficult to do one thing versus another, versus a big store versus, a store that has one or two people. So we're working with that. However, our policy has always been that we would educate and work with individuals, but make no mistake that if individuals repeatedly don't follow our recommendations, there will be enforcement. And we're working with our police and our bylaw officers to enforce these with tickets and fines and so on. So I think that was the question. So the other one was, will the EOH adopt more aggressive stance? Yes, we would. But like I said, our policy is to try to educate initially. And many situations when we get a complaint, we make a call, or somebody visits them and tells them, okay, we do this, that, and they tell us, well, can we do this instead? We'll work with them. But if they're repeat offenders, they're going to get fined. No question about it. I want people to understand that. Then I have another one here from Le Droit. C'est en français. La Cité a fait un don matériel médical comme des masques, des visiers, etc. Au service d'urgence des comités unis de Pescara la semaine dernière. À l'heure actuelle, quelles sont vos prévisions quant à la quantité de matériel? OK. Ça, c'est une bonne question. Je vais répondre en français, puis I'll say it in English as well. We've had shortages. On avait des pénuries des matériels médicaux de protection. Et merci beaucoup pour le don. On a eu beaucoup de dons de plusieurs écoles, universités, collèges, etc. À l'heure actuelle, nous avons assez pour 1 à 2 semaines encore. Par contre, cet après-midi à 5h30, j'ai une réunion parce qu'on vient de recevoir à Hamilton 3 avions pleins d'équipements qu'on doit partager dans l'Est de l'Ontario. Et j'ai une réunion cet après-midi à 5h30 du comité pour voir qui a besoin, qui va avoir la priorité, etc. Donc, je pense qu'à un moment donné, on va avoir pour la première fois assez d'équipements, de matériel protectif. Donc, c'est à attendre cet après-midi, mais ça, c'est des bonnes nouvelles pour nous. On était bien contents d'avoir entendu ça. The question really was about PPE and medical equipment, more specifically personal protective equipment, masks, visors, gowns, those type of things. And we are, we're kind of going week by week, and our hospitals are approaching that. However, we have been told that a couple of plane loads of millions of masks have arrived in Hamilton, in Ontario, and there is a table that's being set, and I'm on it tonight, for the Eastern region, where there will be a prioritization and logistic operations of how these things are distributed across our area. So that is very good news to us. I also want to say that priority will be given for PPE and swabbing to long-term care facilities and retirement homes. And again, I said that is kind of the priority, but we are getting finally, the long-awaited, it's coming. They're finally here. To what numbers and to what degree we'll have equipment, do we have another month's worth or 2 months? I'm not sure. We're going to be finding out later on today. So I'm looking forward to that meeting, because I think that would be, that's very important. We've had a constant struggle with trying to reuse equipment, reuse masks, and reuse gowns, and reuse visors, and so on. So hopefully that'll be rectified, and at least it'll give us a bit more breathing room from that regard, and not have to worry about that issue moving forward. So that's all I have to say, and I'll take a few questions.
Great. So our first question is from Bill Kingston, Newswatch. Bill, you should be able to unmute yourself. Give it a try there.
Yes, I have. Yes. Good afternoon, Dr. Paul.
Hi, Bill.
Hi. You mentioned off the top that you're going to break out the stats as far as City of Cornwall, SDNG, and Prescott Russell.
Yeah.
What was your mindset in making that change now? And as you've mentioned that we're starting to flatten the curve, you've said from the beginning that you were worried about breeding complacency in the community. I guess, can you explain both sides of that argument?
Yeah. Well, first of all, I wanted to look at the numbers and see what the numbers were. As you'll see, there are cases everywhere, even in Cornwall, SDNG, and Prescott Russell. I know that now we have enough numbers to be able to sort of show that we have significant spread. My partner health units have all been doing the same. Just to give an idea of where they are, I'm balancing between people wanting to know and the risk of being complacent. So that's why I always give a caveat that we're doing a good job. Just because we have less in one area than another doesn't mean that it's not here. And that's why I explained, and I'd like to explain to the public as well, that it's starting at a core. It grows out of a big city, and it kind of spreads to us. And it's here. There's no doubt that it's here. Whether we have 10 cases or 20 cases or 15 cases or whatever, it's here. So it's not a risk. It's a balance between complacency and actually people wanting. I've been overwhelmed with questions. I'm not going to break it down any further, though. People want to know, is this little city in Prescott Russell has it or not? I can tell you it's all over. And that's the reason why I'm disclosing it. And we've spoke to my other partners, Kingston, these Grenville, and so on, and they're doing the same, and they're giving county-wide numbers just to give an idea of where they are. That's why I did it.
Okay, thank you.
You're welcome.
If any others have questions, you should be able to unmute yourself.
James got it.
Hi there. Hello.
It's someone else is there?
Yeah,
James?
Standard Friola, if possible.
Oh, go ahead.
Oh, thanks. Hi, Dr. Paul. Todd, just wondering if you could speak to, I don't know if specifically, but perhaps generically, if a store employee like at the Costco in Vaudreuil-Dorion came down with, was testing positive. There's been dispute about whether people should self-isolate if they've been to the store or not. And there are rumors of a big store here in Cornwall who had a positive case. Could you address that?
I don't know about the Vaudreuil one, and I don't know about of any area here. But I'll give you a generic answer. In general, when we have an individual that is positive, we have to look at the history. So let's say we got the result. Let's say now I got a result, and I know that this individual worked at that store, right? So what we're going to do is we're going to go and do a complete contact tracing trace that individual's, what time he or she was there, what his symptoms were at that time, when did he develop the symptoms. Typically what we would do is we would go back 48 hours before symptoms started, just because in case there was asymptomatic or what's called pre-symptomatic. So we have a whole protocol. So we would actually line and do a line by line assessment of where that individual was, exactly what role that individual had. Was he in contact with clients or not? So the degree with which we would warn and follow up would depend on the context. If that individual was just in the back, not the risk. So we look at the risk. So we kind of know like how long one needs, what distance one needs, and what precautions were not taken. So that would be how we would do it. We would not necessarily close down the store, mind you. We would work with the store to ensure that they disinfect and so on. But again, it depends on when that individual was working. And so we do that very, very, very carefully, particularly in this context where an individual may have been in contact with multiple people or in public places. So that's my answer. I don't have any specifics about it. And I'll look at the line. I'm given a heads up on these cases, but at this point, I don't know. But theoretically, that's what we would do.
Okay, appreciate it.
James?
James here from the Review in Van Cleek Hill. Can you tell me, has there been any change in the status of the outbreak at the group home in Plantagenet?
No change there. We've had those 2 cases. We're working with the home. We're testing appropriate individuals. We haven't had anything, any other clients develop it. We do the appropriate testing again. We have a line test. We have a whole procedure of who we test and how we test and how we do the isolation. So far we haven't had any other residents in that area, in that home.
And there haven't been any in other similar group homes in the area?
No. However, I'm glad you asked that, James. This morning I was speaking to our team because we have a team that's dedicated to, I've actually put it together, long-term care and retirement home. So we're going around and calling in each one of them and making sure that what do they need, what's the status, what the risks are, what their gaps are. And I've actually included group homes and lodging homes in that because I think they're also a higher risk as well. So we are treating them as if they were a long-term care facility or a higher risk vulnerable population.
When you say lodging homes, do you mean like a rooming house sort of thing? Or?
Something like that. Yeah, they're kind of in between, but that's what we mean. Yes.
Dr. Paul.
Yes.
Dr. Paul, it's Nelson from Nation Valley
Nelson.
News. I was wondering about if you have heard about the company in Chesterville that's producing that open source portable isolation chamber could be used for up to 2 seniors, and just why aren't the patients or residents of nursing homes going to hospital when they fall ill with COVID?
That's a complicated one. I can't say that they don't all go. It depends on the situation. It depends on the context. The portable isolation units are welcome. I know that I've heard that company. Are they the ones that do the negative pressure ones?
I don't think so. No, they've it's a design from Italy. It's open source, and they're ready to roll them out. They say they're in the former Nestle plant. And they've been trying.
That's something that we should know. Have they gone to Ontario together?
I'm not entirely sure. I should find out.
Because because those are the type of things that we need to do. We need to give tools to a lot of these homes. A lot of these homes, as you know, sometimes they have 2 in a room because if they're built certain time. The newer ones are isolated. They all have single rooms, but some have multiple residents in one room or one area. So that would be welcome there. Whether or not a retirement or LTC or long-term care resident goes to hospital depends on the individual situation. I can't comment on that. Thank you. I'll take one more. I've answered them all. Thank you very much, everybody. See you tomorrow.